very much, and we go on with the history of MiECC, and Yves from France is going to start.
Okay, thank you very much. First of all, I would like to thank the organizers to give me the opportunity to be probably the old guy here. And I'm pretty glad to see that so many questions have been raised over the whole day. It has been a long day for all of you. And I will try to make the connections with the arguments why we try to start this new concept of minimally invasive. And even if the term of mini was termed early on, the idea at the very beginning was to be minimally invasive. So I think it's simply to come back to something. I think I should use this one. Not at all. It doesn't work. Could you help me? Thank you very much. So just to remind you, over the years, conventional CPB circuits have become sophisticated and more complex. And in the old days, I mean in the 1990s, cardiologists came up with the idea that that's probably not what we need, because we have to confess that there are side effects linked directly to CPB. That's a fact. So angioplasty developed in the late 90s, and more cardiologists were convinced that this was the solution. And even if it was not dedicated only to CPB, CPB in the context of CABG was clearly targeted. But nevertheless, superior long-term outcomes for the patients were linked to surgery. And this was the starting point of our reflection, not only in Paris, but also in Regensburg. We had slightly different views, but the common starting point was there. What we had in mind is to come up with a very simple, basic idea to ensure good perfusion. We might come up with a simplified, less sophisticated, closed circuit with a non-inclusive pump. That was a basic idea. That was the starting point. That was not the end. And I stress this point. Our idea in Paris was, since the start, to develop something that would be a fully integrated CPB system that would be able to reply to the needs of surgery in general, not CABG only. I make that very clear. In our hands, in our idea, it was to develop something that would answer the demands of the surgical needs for the patients, but in a more simplified fashion. And you can read the different publications that we had, so we can trace that back. Similarly, since the beginning, it was in our eyes, in our hands, a major issue to be safe. So when I hear over the years the criticism that minimally invasive extracorporeal circuits are unsafe, per se, it was our intent to be safe and to maintain these good surgical results that have been testified by the conventional circuits. And it has been stated several times, and can only support this idea, that there are positive results that show that the overall morbidity and mortality are lower as with conventional circuits. What we have focused since the beginning, and that's probably one of my inputs, biological markers may be slightly different. And I try to convince you that there are a couple of biological markers that may have direct clinical inputs. That is, and you have stressed it before, a reduced hemodilution. That is a better preservation of the immune response. That is a better management of the anticoagulation with less bleeding, and you have heard quite a bit of this. But let me go back to some of the results I didn't present so far. And that comes back to the fact that so far we have considered mainly the hemodynamic aspects. And you all agree that plasma is the only major fluid compartment that is existing per se in our whole body. But if you look at the physiology of the human body, plasma is only a small fraction of the body fluids. And this is what we're dealing with. We try to use plasma or blood, but mainly the fluid part, so the plasma, to perfuse the tissue. And you have heard quite a bit about microcirculation. And the whole concept behind that is there is a compartment of plasma, and I would like to share this with the tissue. So it is basically a two-compartment strategy that we are using. And I will try to give you some arguments in the more recent work that we did that's probably a little bit too simplistic, and we can come up with a slightly more practical, more clinically relevant model. Where we have shown that plasma is separated from the interstitium by a membrane that is highly sophisticated based on endothelial cells. These cells will react, per se. They are not only sensitive to immune cells, and the dysregulation of these cells will increase the permeability. Increased permeability will be responsible for some side effects, especially the edema that we have seen, and edema can be seen also as a barrier between the plasma sector and the tissue. IL-6, and we have published this very early in, can be reduced with the minimally invasive circuits. And that's probably one part of the explanation why we have better clinical results. It's not the only one, that's not but what I will state. What we try to explore is a slightly more complex system, but finally, the only one that you have been taught in your physiology courses, meaning that you have three compartments: the blood, the interstitium, and the cell. Not only a common tissue sector. And so we try to explore this model with modern technologies. But here I have to take you out of the OR, because the tools I had to use were based on nuclear magnetic resonance, and I have no device that I can bring to the OR. So I took the problem out of the OR into the lab and used NMR technology to investigate how can we fit, and I will be very simple on the NMR part, how can we fit the T2 sequence with a better model. And we showed in a publication in 2014 that the T2 signal can be best fitted with a 3-compartment and 2 exchange rate model. So what I would like to give you as a take-home message is that the rates of exchange through the endothelium are the ones that you know. We would like to preserve them because they are the fast rate. But if you increase edema in the interstitium, you will build up a blocking step to have the transfer of oxygen, of nutrients into the cells. So having the minimally invasive strategy available now on a clinical level, you are better fitted to preserve the homeostasis of your plasma sector in order to achieve better perfusion. So my message for you is respect and take care of the physiology and preserve your interstitium, because that will be where there will be a major difference. Collectively, minimal invasive extracorporeal circulation technologies have given us the new tools that will allow the future perfusionists to be able to respond to what we are intended to do, meaning cover the needs of the patient. And I wouldn't subscribe completely to the idea that we have to oppose the surgical needs and the physiology needs. I think that we have to face what are the needs of the patient, and that's what surgery and perfusion should bring together. I think that we have achieved quite some advancement in that field. And I can only subscribe to the idea that this is possible when a team is working together. I had the great opportunity to work in a place, a clinical setting, where people were able to talk together, to come up with ideas, confront their ideas, and we were able to offer this opportunity to do minimally invasive circuits. We were able to integrate that in the whole department. My idea at the very beginning was to convince nobody, leave all the people free, and some surgeons were completely reluctant at the very beginning. And I was more than happy to see when they came later on to me and say, why couldn't I benefit from this technology? So I think that teaching and convincing is more important than forcing people to do it. So I can only subscribe for the young generation that be educated, be taught, have mentoring, and you have heard it just a couple of minutes before. Work together, don't fight, but try to discuss. Scientific discussion is really constructive. And I have to acknowledge more specifically Olivier Bical, who let me complete freedom. And he was not always in agreement with me, but had confidence and said, I don't understand what you mean, but go for it. So he was really a great mentor. Unfortunately, when he retired, I saw also how weak collaboration and how weak collaborative work can be. So thank you very much for your attention.
Thank you very much for this very compact talk, and as a pioneer in this field, we thank you very much. So I want to ask you a brief question. So you're talking about to protect the interstitium. And so do you find any ways of monitorization to understand the status of the interstitium during the operation? Or, for example, what do you think about goal-directed fluid therapy or something else?
That's a good question, but I don't have any simple technology that I can bring to the OR yet. There are quite some research ideas that we're working on. So keep track. I don't promise anything, but I think it will be important. But many of the good ideas have been addressed, like fluid management. You can understand if you preserve the plasma concentration of proteins, like the colleagues in Finland have addressed. Why is albumin at 20% concentration superior to 4%? Simply because you preserve oncotic pressure. So you can understand, you can rationalize what they are talking about, and I think they are on the right track.
Thank you. And one question from the previous session. Do you think any places for improvement in the setting of the MiECC systems in the near future, technically or product-wise?
I think that I subscribe to the idea that many of the good products are around. It's a matter of how we use them. Then there will be a major challenge for the future. Can we integrate at a higher level all this information? And that means that, and I think that Hans-Jörg has addressed that, we have not to be afraid of innovation. We have to adopt it and go forward. I'm confident that the next generation will be fond of innovation, and I think that Mike will have quite some good ideas for the future.
Thank you.
Thank you so much.
Questions?
Allow me one question.
Yeah.
Sure. Obviously, our history as a MiECC goes back to 1 decade, but you look back to more than 1 decade. I think you used to call them minimized perfusion circuits. So as a researcher, sometimes you get dreams and you think about the future and how it could be like. So when you look back, what disappoints you most in the current situation and what encourages you most?
When I look back, I would say what discourages me is, as a physician, I see that we were not able to convince more people. Because I think that is the right direction, and all of you have pointed many of the arguments that I could give also. Why didn't we convince more? It's a difficult question, because I think that in many congresses we tried at least, but we didn't succeed. Maybe because we have the message too close to our community and we have to bring it outside our community. That's what I try to do now, keeping my casquette as a researcher more than as a clinical physician. We have to convince people that perfusion per se is a research topic, that we can do better, that we have to understand what we are doing. Many people are talking about this precision medicine. We are completely in that line. Many people are talking about personalized medicine. We are in line with it because we are treating individual cases and we have to adjust each time. So we should be almost the leaders of all these innovations for the future. We're not quite there, but I'm rather optimistic. And when I have to address the point, what are my views for the future? I think that integration will be the best way to summarize that. I think that artificial intelligence has to be integrated in the pump. It's not a matter of how can I improve a little bit the monitoring of this or that. We have to integrate all this information, and that's beyond the time frame of what a perfusionist or surgeon or whoever is running the perfusion, the team needs, because the patient is not a constant, it's a variable. And if we can integrate that at a higher level, I think that John has shown very nicely the way we should go, not only for neural monitoring, but for monitoring in general and perfusion per se. So I'm pretty confident for the future.
Thank you very much for a very inspiring talk.
Thank you.
Thank you. Thank you very much.